So we are week 5. It's quite amazing how quickly this does go. I did my review yesterday, so you have 2 already. There is one for Sunday, and it's a different Zoom. So I did announce that in the announcement today. Apparently, Professor Luminoso's Zoom, the permanent one, doesn't work anymore. One of those things. So I had to change the Zoom number, making sure that you have that correct. So this week 5, we're doing 23 and 24. It's sensory, neurological, and muscular skeletal conditions. And you will see some of this stuff on the exam. And then we have our NCLEX questions, and make sure that you turn them in the right, which ones I want. Also, get the best grades you can. Remember, you want a 78 or more because it is actually 1.25% of your total grade, each one. And that's quite a bit if you think about it. And that little bit can take you from a 79 to a 77. And I've seen it. So just at least get your passing grades. I mean, many of you do your hundreds, which is awesome, but just be aware because once you turn them in, that's turned in. I can't change it, okay? So let's go ahead. We're going to do our PowerPoint and then we're going to go on to our Kahoots. Anybody have any questions about anything? Happy Friday night, right? It's hard to have a Friday night class.
Remember my name.
There are some classes that start at 8 o'clock at night on a Friday.
We have a community
You have
class
one to
after this one.
follow?
Yeah.
Oh, okay.
Till 10:30.
Well, see, so you all know all about it.
Yeah.
So here we go. Let's start with this one. And, the lead professor is putting in objectives, telling you the things that you need to know about each chapter. So when you go back and look, these are some of the things to look at. So ears. Children are born, and we know that children have shorter, straighter tubes, eustachian tubes. And what that means is, they can hear, but what about if they get mucus? It's going to go straight in there because it's easy, right? So we know eustachian tubes, they keep the ventilation in the ear and they protect it, but it also, there's a lot of drainage that can drip with it. But remember, it can fill the ear up too. Now, there's 2 types of ear infections. One we call swimmer's ear or otitis externa. I don't know what's more painful, the media or the middle ear or the externa, which is the outer canal. They both hurt a lot. It is extreme pain. You touch that little bit of the ear or that little flap on your ear. Oh my goodness, the children really, really cry. So what do we do with it? Well, most of the time, unless there's, a lot of debris in the ear, we'll just put these children on ear drops. And the reason why we get the debris out is so that the drops can go to the ear and the tissue, okay? Otitis media. This is an infection. It is a bacteria. This is one of those diagnoses that is not viral and bacterial because in your throat is normally staph. So we do treat it. We do treat it with like amoxicillin, and we'll make sure that these children take the whole course of it. Okay? That middle ear gets inflamed, it gets swollen, and it really, really is painful. If we don't treat it, it can go up into the mastoids, into the bones, and create even more problems. So very important that we treat it with exactly what the doctor says. 7 days, twice a day, we need to do it. Now, children do get hearing loss. So some of them are from birth. That's a congenital hearing impairment. It could be structurally that wasn't made correctly in the ear, or maybe the ear wasn't formed. We've seen those things. We know that there's the conductive where it doesn't transmit through. And there's also those ones with the nerves pathways. It doesn't work. Sensorineural type of ear problems with hearing. These children, you will see that they don't respond to noise. If you jar their crib, they'll jump and they'll do that startle or moro reflex, which was on the last exam. But if you clap your hands next to the head, they don't know it, okay? So, one of the problems with children with hearing impairment is that they don't hear, they can't talk well, because you need hearing in order to have good speech, and they can't express themselves. And they don't understand what you're saying when they're littler. They don't know sign language or lip reading or any of those things yet. It is frustrating. So these children will show that with some bad behaviors. So when you have a child who does have hearing impairments, what are some things that we should remember? Well, be eye to eye, not above them, eye to eye facing that child. Make sure you're looking at them when you're talking, very short sentences. Don't go on and on and on. They don't, they'll lose it. Those little short little sentences do help. And then don't try to talk louder. It's not going to work. And then don't over exaggerate the way that you're speaking to them. Talk normally and slowly. And these children pick up a lot more. So, as a nurse, that's what we would do. So, a nurse has been signed to care for a 2-year-old boy who has been scheduled for a myringotomy with a tube insertion. How should the nurse explain this surgical intervention and its indications to the child's parents? What instructions should the nurse provide the patient before discharge? Now, whenever you see a question on these PowerPoints, the answers are always down in what we call the note pages part of it. So, a myringotomy, what is it? Well, a child who has chronic ear infections, which means the drainage process isn't going on. And it needs an outlet for it to drain, which is this tube. They'll put in these ear tubes and they do ear myringotomy. I had one in August, believe it or not. And because I was having problems with fluid buildup, I couldn't hear, and they put the tube in. So I'm very aware of what ear tubes are and the whole process of getting it done. And I know why these children are put to sleep because it is scary, and even for me as an adult. So, myringotomy, we put that tube in. It's because of those ear infections that do not go away and they're just chronically one after the other. And then some instructions. If we see that tube fall out, especially immediately after surgery, we need to let the physician know. Usually they will fall out, eventually. The ear sort of works its way out, but it's done what it needs to do, usually. There are children. My middle grandson had to have it 3 times, put these tubes in. They kept falling out. I think they put some titanium steel or something in at the last one to try to hold it. And so far, we're good. It's still in there. Now, eardrops, very important, and giving them something for pain. Acetaminophen, like your quiz, is all they need. Now, years ago, they used to give them some hydrocodone called Hycodan syrup to these children, and we found out it was dangerous, and children were overdosing their children because they're in pain. Let me give more and more. And they found out Tylenol works just as well because Tylenol don't take too much. Okay. When should we call these doctors? Well, if immediately the tubes fall out, yes. How to give eardrops up and out, down and back? How do you do it for the aged children? Cool compresses really help because the inflammation, it's swollen. You put cool on it and it constricts, right? And it helps take away that pain. So never put Q-tips, anything in that ear, because you don't want to mess with that ear tube in there. And you don't want them to the child themselves sticking things like the end of a pencil, the pen, the little caps, sticking them in there to itch because sometimes they itch. None of that should be done. So, eyes. What do we want to know about the eyes? Well, we know that eyes are being formed, they're intrautero. I want you to know that not all eyes are open at birth. You can have an infant born at 24 weeks gestation and their eyes are still fused shut. And then in about a week, they do open. So I thought that was amazing when I went into the newborn ICU and started to learn them. We know that when they're born, they don't really see colors. They don't really see things clearly. Um, they don't cry until 1 to 3 months old. And seeing a little baby cry is so sad when you see those little tears out because they do not cry if they're not in pain or don't need something. One of the other things is they're born with both eyes working separately. It's called binocularity. So when this eye works here and this one works here and not together, they don't know where to grab. If you put your finger in front of you, both of your eyes will focus there and we can grab something. That depth perception is good. So one of the things with eyes, unless there's something severe, we don't start testing them to about 2 or 3 years of age. Now, dyslexia. Now we're talking about speech. And many children do have problems where they turn things around, the numbers, the words, they just don't understand. They don't recognize words. And these children really need therapy in order to get through this and practice of reading words, et cetera, et cetera. Um, One of the children things with hearing comprehension and speech, hearing you need to have, and then that will help with speech, and then the speech and understanding will help you with practice that dyslexia. Now, visual impairments. You have myopia and hyperopia. Now, the one thing I've never understood is why do they say nearsighted when you can't see far? And why do they say far-sighted when you can't see near? It's opposite of what you think. So we know these are due to many different things. When I was younger, I did have myopia. Well, now, obviously, if I got glasses on, I have hyperopia. I can see a flea a mile away, but I can't see my fingernails in front of my face. And that's normal, all those changes. Now, there are different sort of visual impairments where you have strabismus. Strabismus is when both eyes look at something, but they don't work together and they can't see it clearly. Amblyopia is one lazy eye, where it's down, up, backwards, forward. Doesn't matter. It just doesn't line up like the other. And it's usually one eye. And what we do is the muscle of the eye is just not working right. So we need to strengthen a muscle. So we cover the good eye and make the bad eye or the lazy eye work. And that patching periodically during the day helps strengthen the muscle, and that's usually all it needs. So, with the amblyopia, like I said, it's trying to, and anything with children, it's early intervention. As soon as we see something, let's get it fixed, right? Again, that is with that patch and helping. Sometimes they need also classes that also help them correct it, but the patching is good. Strabismus, like I said, this is where the eyes don't work together. Now, we know at first there is that binocularity, but it becomes to the point where these eyes, there's no coordination in with them. And then if we don't straighten it out, you could have permanent visual problems. So these children, either glasses or strengthening those muscles, or maybe even surgery on these children. Now, eye strain, I'm sure you all have it looking at computers, reading books, etc., doing assignments, and it's really, really common. With eye strain, they do really need to go to an ophthalmologist and get their eyes looked at to see what can be done. Is it a visual problem that needs corrected? Because when you can't see those eyes, the muscles, whatnot's going to get inflamed and they're going to hurt. They're going to ache. And then you might squint. And then you can't see it, so you're not going to pay attention and you look up a lot. Also, headaches. Usually, headaches are what brings that child in for an eye exam. And then, of course, you see difficulties with schoolwork. And then, the teacher puts them up front, but that doesn't always work with eye strain. Now, conjunctivitis, very common in children, right? This is an infection. It is bacterial. The conjunctiva gets all inflamed, and there is this green, gooey goop, right? This exudate that comes out of the eye. You could call it pink eye if you want. A lot of times, in the corner of your eye is a lacrimal duct, and it gets blocked and you can see your eyes are actually attached to your throat. Ever have an eye drop and you can taste it? That's when you realize that there is a connection. Well, again, what bacteria is in the throat? It's staphylococcus, right? So that comes up into the eye. So how do we take care of it? Well, warm compresses get rid of all that exudate, and then there are eye drops. Now, if we use an eye ointment, whether it's an adult or whether it is, a child, make them aware that they're going to see blurry at first, right? That ointment is blurry. They say, oh my God, I can't see. And it is scary. And one of the things that's not in textbooks, and I think that should be told to all parents, is these children's pillowcase should be changed daily, or else they're going to keep infecting themselves. It's one of those things that through my years of nursing that I have told parents. So we have itching, we can have tearing one or both eyes. You might see swelling in the eyelids. And this child is going to be, it's bothersome. So they might be that irritable, distracted child. Hyphemia. And this is when you get that little blood spot in the eye. And you're like, oh my God, did you get hit in the eye or there? Sometimes it just comes out, these things, all right? Um, what you do is we want to keep the head of the bed elevated. And maybe they'll put some sort of eye drops in there or eye ointments. So it does go away. It's not going to stay there. It is transient. Now, retinoblastoma, this is cancer of the retina. It's malignant. What you see with these children is like, ever go out your back door and you have a light on and you see in the distance, if you live more in the country, of course, or even in a bigger backyard, if you have a cat or a dog or there's an animal, you see these bright, shiny eyes. You can see them glowing. Well, that's what that eye looks like. And this picture shows you that left eye is white. It's called a cat eye reflex. It's also called leukocoria, and it's telling us, oh, something's going on. We know there's going to be some loss of vision, and if it's big enough, it's going to be causing the pain. What they do is radiation, chemotherapy, and they take the eye out completely. So this child will eventually have a glass eye. I used to go to high school with this boy who liked to tease the girls, right? Make them go, "Ooh." He would take his eye out and roll it around on the desk, and I had no clue what he was doing back then. And then he'd put it in his mouth, lick it, and stick it in the eye socket. I didn't understand until I started teaching about retinoblastomas, and I'm sure that's what he had, right? Why else would you have a glass eye? All right, here's some more um, type of objectives, and let's see what we happen here. Nervous system. Well, the nervous system is basically the captain of the ship, and it tells the body what to do. It tells you how to move, it tells you if you're in pain, all of these things. Now, there are some neurological disabilities that can happen. It could be because the brain didn't form right, or maybe there was an injury, like head injuries can cause it, infection, and also hypoxemia. You're going to see that lack of oxygen. It can cause that too. One of the things that if we see a child and all of a sudden they're just not making sense. They were alert last time you did an assessment, were in the room, and now they're just talking. What are you talking about? Or they're in the hallway looking for their room and it's right in front of them. Something's not right. Well, take their blood pressure. And the blood pressure, you're going to see it low. And what does that mean? And why do you have altered state of consciousness? Well, if you don't have blood flow to the brain in a certain, pressure, you're not getting oxygen. So this is directly related to hypoxemia, okay? Fever can also take away oxygen. It burns some oxygen. And as this says, it increases the oxygen need by 10%. So lower blood pressure, fever, now you're in more trouble, right? What would you do? Well, get that blood pressure up first, get them into bed. There are medications we use. We use sedations and we use anti-epileptics. Sedations are used like diazepam with seizures. We use a lot. Anti-epileptics, you all heard of phenytoin, dilantin. You heard that through your pharmacology. Seizures can be all type, and one of the things that happens after these grand mal seizures is something called a postictal state. And they don't know what went on. They don't know what happened. They're confused. That's an altered state of consciousness, and also any increased pressure. And that's how we know a head injury is getting worse, by that altered state of consciousness. They're starting to forget, they'll ask the same question over and over again. Now, Ray's syndrome. Ray's syndrome is caused by a child that gets aspirin. There's also some metabolic and some things that need to be in there, but many children can get Ray's syndrome when getting aspirin. That's why if you ever see a parent saying, well, my kid has a fever, I give him aspirin routinely, you're going to say, that is not a good idea. Let's give him some acetaminophen or some ibuprofen, okay? As I said, there's some sort of metabolic genetic things, that can also cause it. Now, Ray's syndrome is really, really bad. It's a bad thing to get. It requires the pressure in the brain gets really high. These children, you have to sometimes put in a breathing tube, maintaining airway because we want to keep oxygen up in the brain because of the pressure. So we intubate electively to do that. And it's a fluid electrolyte balance that we also have to look at. So never use or tell a parent. There's only one diagnosis that we ever recommend aspirin for in children, and that's in the cardiac chapter, Kawasaki. So sepsis, what does sepsis do from? Bacteria, virus, fungus, all of those things. It's an overwhelming systemic response. And it's these children, especially the younger ones with a lower immune system, are really get overwhelmed by it. Very sick child. Sepsis, they go into shock. What are you going to see with shock? Well, you are going to see tachypnea, tachycardia, low blood pressures, poor urine output, decreased capillary refill, and, with sepsis, because it's overwhelming systemic, you're going to see these really big fevers. These children, some of them don't make it. It depends on how quickly we detect it. Sometimes with infants, it might be a couple of apneas or a couple spells of bradycardia. That's a true thing that's telling you this child, this infant might be going into septic shock. Now, meningitis. Meningitis is an inflammation of the meninges, and the meninges cover the brain and the spinal cord, okay? Again, this is bacteria, virus, or a fungus. Funguses are actually the hardest one to cure because it's the least common, but probably one of the most severe. We know that meningitis is caused by a lot of the times Haemophilus influenza. It's just another type of infection. So when do we see these things? Well, these children, you will see bacterial meningitis in the younger children, and that's because they don't have an immune system to fight these things. And older kids, their immune system is better. They feel they don't get it as much. I mean, they have to be already something going on, or an immunosuppressed child. All of those things can cause it. What do we see in meningitis? Well, number one is a headache, right? And a fever. Now, with the headache, the increased intracranial pressure from all the swelling going on, you see the drowsiness, the delirium, the restlessness, irritability, and then headache so bad they're vomiting. And then you get to nuchal rigidity. And infants, when they have problems with their head and the swelling, they have this. You cannot mistake a neuro cry in an infant. It's really high pitched. I call it, it's like putting your nails on a chalkboard. It's so high. You can tell. You don't want these kids to cry. Now, encephalitis is an inflammation of the brain, but only the brain. Okay. Again, this is a headache. Um, it is, you get drowsy, going into a coma with convulsions. We see a lot of things we see with meningitis, but again, it's only the brain, it has nothing to do with the spinal column. Again, supportive. We're just going to support these. Usually these things are more of the viral. And so it's the ibuprofen, it's the acetaminophen, and then making sure anything with the brain, you got to make sure that you don't overload them with fluids. Overloading with fluids with a brain condition will put more fluids in the brain and cause more issues with it. And this child is going to need a little bit of oxygen in order to help support them. Now, brain tumors are something that happen in children. It's the second most common of all of the type of neoplasms. And usually it's school age children. And how do we diagnose these things? Well, number one, you need a symptom. You're going to see headaches unrelated that can wake you up in the middle of the night that are getting worse and worse. And then you're going to see vomiting that's not related to feeding at all. That's the initial. as we continue to go on, it gets to be that drowsiness and seizures. Now, hopefully, with the headache and the vomiting, they go in and they're going to do whatever laboratory they need. They always do electrolytes, but the head CAT scan, MRI, and then if we think there's seizures in there too, we're going to do that EEG to check the electrical activity of the brain. How do we take care of these tumors? Well, let's give radiation. And remember, radiation depends on the size of the child, if they can do it. And you know how small and what area, is it small area or big area? But doing radiation shrinks that tumor so they don't have to take out so much of the brain, right? And then, of course, chemotherapy, and then they go to do surgery. Some of the other things you might see is, the eyes, nystagmus, strabismus. You're going to see them, their gait, their walk. They're just going to be behavioral different because they've got something occupying a space in their brain and it's doing different things. Your body, your, conductor of your body's not working that well. So we mentioned a little bit about seizures, so let's go a little bit more. So the most common is those febrile seizures. And most parents think that a febrile seizure is caused by a big high fever. And I have never seen a seizure because the temperature was 105. I've seen 106, no seizures. A febrile seizure happens when you have a child has no fever and 30 minutes later they're 101. It's the rate of rise, how quickly it went up. The brain goes zoop zoop. Oh, I can't handle this seizure, this fever, and it has a seizure. Now, they usually by 6 years old go away. They grow out of them. Usually it's not epilepsy. You need 2 or more seizures a day in order for even to consider their epilepsy. And we just treat it with, it's a virus, usually these febrile seizures. We treat it with acetaminophen, ibuprofen, and fluids. It's just symptomatic treatment. Now, the tonic-clonic is that grand mal. That's when you think they're foaming at the mouth. Their arms and their legs are, moving back and forth. That is what we call it. Now, when they're older and can sort of understand what's going on, they do have an aura, many of them, like they know it's coming. And, they're told, sit down. So they have a seizure, they're not going to fall down, right? Then they go into this tonic-clonic, the legs and arms going back and forth. And when they wake up, they're postictal, which means they're not remembering what's happening there, right? So when we have tonic-clonic that continues for 30 minutes or more, we call that status epilepticus. This is the child that's going to get diazepam IV. And this is the child that we will be giving some sort of anti-seizure medication. Now, there's another sort of seizures called partial. And the partial means it could be they have a blank stare. Could mean they got a twitch of the eye. It could mean one shoulder moves. It could be very subtle that they don't even know they're having them. And those are actually hard, to see because you don't, just think the person's not paying attention to you and they're having a seizure, right? So seizures, what do we do? How do we treat them? How are they diagnosed? Well, first of all, what type is it? Is it from a fever? Or are we having multiple seizures? Are they tonic-clonic or is it that blank stare? And that's going to depend on what drug we do. As I said, we're going to do a CT, MRI, we're going to do EEG, and then we're going to be doing laboratory tests. This is saying to rule out poisoning. I mean, kids put everything in their mouth, right? And poison can cause seizures. So it's good to rule those things out. There's many, many, many type of seizure medicines. And depending on what type of seizure, depends on what we're going to give them. And we usually start with one and then we keep adding on till we get them controlled. There's some children on 3 and 4 different seizure medicines because they're having almost nonstop seizures. And yes, that can happen. And that's what we want to do is to control them. If we control these seizures and they don't have them, we are giving this child a better life, right? They're saying some of the long-term medicines are gabapentin and are carbamazepine. Now, gabapentin is also used for pain. Have you seen that in adults? Anybody? Because it deadens the nerve. That's what they do. They deaden that spot in the brain. They numb it so it can't spark, so it can't cause a seizure. Very simply, that's what it does. We need to teach our families and our children medicine, same time every day, never, ever, ever just stop. As in, if you see that you're getting to the bottom of the pill jar, order more so that you don't run out of them. Very important. Now, there is said today to put these children on a ketogenic diet. They have found some very good success in it. It's high fat and low carbs. And this actually puts you in ketoacidosis. And they say that does prevent convulsive episodes. So, a 3-year-old boy is a new patient with a diagnosis of seizure disorder. What possible types of seizure might the child be experiencing, and how are they characterized? What aspects of this boy's seizure activity should the nurse observe and document? And what instructions regarding the seizures should the nurse provide? Well, usually, what's the first one of seizures that we're going to rule out? It's something we can measure. And that's a fever, right? If it's a fever, we can measure that. So we know that most likely that seizure was due to a febrile seizure, due to a fever. We do have something called a Jacksonian seizure. It's like a partial, same thing. But as I said, it's like one area. Could be the eye twitching, or it could be, one finger, one arm, something, one something starts moving. We know there's grand mal and there's petite mal. We've talked about those. And as a nurse, what is our job? What do we do if we see a seizure going on? Well, number one, if you see a seizure going on, we need to look at the clock quick. What time is it? We want to know exactly how much time it is. We need to protect them from injury. So they say turn them on their side. So if they vomit, they're not going to aspirate it. Never stick anything in their mouth, but have suction at the bedside. Because if it's vomiting and there's no room for more vomit to come, they'll aspirate that. So at least you're suctioning that not in the mouth, but to keep that area around that mouth clean. And if you're seeing this going on, always call 911, get some more help there. Now, many kids have a lot of toys in their beds, right? So some of them can hurt them. And if they're tonic clonic moving, they can, cause abrasions and lacerations. So these are things that we need to think about. Putting the head of the bed down. If they're admitted with seizures, I want padded side rails because they can bang those side rails and really hurt themselves. So let's go into some more things, cerebral palsy. Now, cerebral palsy is what does these children look like? Well, some are very minor. I was just watching a TV show, and the cameraman had minor cerebral palsy. So very functioning, alert, talking well. And then you have the child or who will become an adult with, really severe cerebral palsy, spastic. where I used to do clinicals, my little Jonathan, very severe spastic cerebral palsy, and his intelligence. Now, we used to, many years ago, when I was a teenager, we didn't really do all of these interventions, speech and physical and occupational therapy. Well, today we do. And Jonathan, he's 7, but he has a pad and he can talk on it. And he's learning colors and numbers and shapes where this didn't happen before. So, yes, they are behind, they are intellectually and developmentally behind, but they still can be learned, right? So, when do you suspect something like cerebral palsy? Well, why do you think we do all these developmental milestones? When they lift their head, when they turn over, when they crawl, when they sit. These are things we're looking at. And if they are behind and they've been maybe a premature infant, we're going to suspect it could be cerebral palsy. And what does that do? Well, it makes us earlier in life start intervention to try to catch these kids up to the other kids, right? So sometimes you have things that could be mistaken for seizures. And the thing is, if we thought they were seizures, we give them medicines, they're not going to work because they're not the brain having sparks and causing seizures. And these are the ones that are down here: the benign paroxysmal vertigo, this dizziness, night terrors. And kids have night terrors, especially your toddlers and preschoolers. They wake up screaming and they don't really know what they're doing and walking around at night. Again, my second grandson had those. You have young children that hold their breath and turn blue, right? Those could be mistaken. Cough, and then these rage attacks. And that's just behavioral things. And then what we call a prolonged QT, it's just a cardiac condition. I've seen one of those. So, cognitive impairment, we look at things like their level of consciousness. Are they alert? Are they learning? Can they remember what I just taught them? Or coming back, next week, do they remember those things? So short term, long term memory, and are they understanding those things? And then there's thought processes. Are they have good judgment? Do they know right? Do they know wrong? What's their moods? Are they good mood? Are they always angry? Those things that we're going to be looking at. And then their expressive language. Are they talking one word by 1 year old? Are they doing multiple words, 4 word sentences by 2 year old? So again, developmental milestones we're looking at. Are they there? And are they smart? Are they learning? Do they know to put blocks on top of each other? Are they learning in that regard? So intellectual impairment, what we say is if you have at least 2 of these, there's an impairment. And these are things, again, a lot of these are right off your growth development. Communication, self-care. I mean, children do, young kids hold their bottle. That could be self-care. As in toddlers, are they trying to dress themselves? Social skills, do they get along with other children, other adults? Um, do they follow directions? Are they working, if they're in school, are they able to keep up with the colors and the alphabets of the younger kids, right? Now, the prenatal period, we see PKU. It can cause intellectual impairment. That's why we do those little, dots on all kids, right? Those little 5 dots. And we look at the PKU because it's a metabolic problem. Now, one of the things we don't think about is hypothyroidism. Now, children born with hypothyroidism that we don't recognize are not getting enough of their thyroid hormone, and it will show intellectual impairment. We usually can find it because usually children with hypothyroidism are born and do not have a bowel movement in 2 days. Any child not having a bowel movement as a newborn in 2 days will be getting tested for thyroid hormones. And it could be that. There's a couple other things, but that's one of them. Fetal alcohol syndrome, well, you've had all this alcohol in the brain, right, of these infants, which could cause intellectual impairment. Any sort of malformations in there, and children are born that way. Down syndrome, of course, and any infections. And then, like I said, those hypoxic anoxic episodes at birth, that lack of oxygen. Some kids tolerate it well, and some kids a short period of time, and then they have cognitive delays. Now, sometimes as they are growing, things can cause it. Meningitis, of course, inflammation of the brain, encephalitis, neoplasms, brain tumors, all of those things can cause cognitive and intellectual impairments, right? And then, of course, living with a family that doesn't stimulate them, that they're not getting what they need at home. These children will just give up, go into despair, and that's it. Mm. So, how do we approach these children? What do we do for them? Well, we know that these children can do a lot more than what sometimes they even know that they can do. We need that these children need to be involved and put in situations and have experiences, that stimulate them emotionally and mentally, right? We need to praise them for what they do good. We don't need to keep telling them what they're doing wrong. If you're always told you're doing something wrong, you don't believe you can do it now, right? And remember, these kids are sometimes trying so hard, but they can't. And that again is frustrating. That's that inferiority. They want to do it, but they can't. So it's important that we, when they get angry, try to help them understand and, to get them out of that anger stage. So a 6-year-old boy developed cerebral palsy from a near drowning, and that was 16 months ago. His parents would like to know what they should expect of the child regarding his education and future. Why would a near drowning cause cerebral palsy? And what should the nurse tell the parents about realistic goals? Now, why is near drowning a problem for possibility of this child having cerebral palsy? What happens there?
Brain damage.
Lack of oxygen, right? The brain damage is due to their lungs fill up with water and they don't get oxygen. So it's that hypoxic anoxic episode which depletes the brain from oxygen, which causes that brain damage. Yes, it does. Very good. So, drowning, how much are they going to be delayed? Will they, or will be a lot? I'm telling you, all children are different. Depends on how long they were under, right? How quickly they're pulled up, how quickly they started to breathe, what sort of treatment they got, how quick they got those things. And again, the goals should be set, and as they meet them, you make the goals more and more. Do achievable goals that they can get with work, and then work on, being more than they ever thought they could be. Like my little Jonathan. I mean, if you look at him, he's a spastic cerebral palsy. He looks at me and his hands goes up and it gets all tight and he smiles so hard. And you would look at him and say, how much does he know? Well, he knows me. He knows that I'm going to go give him a big hug and a kiss because that's just what I did with him. But how much can he express? And he's nonverbal. So that pad that he has gives him that facility to be able to describe himself. So let's now go into head injuries. I've talked a little bit about it through this, but a little bit more. Head injuries are a major cause of death in children older than 1. Remember, toddlers, what do? They jump off of couches and dive bomb onto the floor, right? And head injuries. It's just, they're into everything. It's, a toddler. A concussion is a temporary disturbance of the brain. And usually with a concussion, a true one, there's going to be some sort of unconsciousness. They're going to lose that consciousness. And then they wake up and, like, where am I type thing. The children's response to a head injury can be different than an adult. And I'll tell you how. An adult can get a head injury and they usually do not vomit. They'll have a headache, but they usually do not vomit. A child will. And that is the difference between them, okay? So, shaken baby syndrome. This is when the kid is shook so hard that the brain shakes and it creates really bad brain injury. It's if the baby is alert, you will see them drowsy. That you don't know if they're blurred vision unless they're older because they're walking into things they can't see, but it's the headache and vomiting. And it get to the point where they could even be short of breath. Because remember, where is the brain center? It's at the base of the skull. That's where you breathe, your heart rate, your blood pressure, right? And if shook and it damages it, they may not be able to breathe. They may not be able to maintain even their own bodily functions. So a 7-month-old's brought into the ER by her mother's boyfriend who was babysitting for her. The baby is in an irritable state. The nurse overhears the physician say that he suspects shaken baby syndrome. What might cause the physician to state this? And what signs should the nurse look for that might indicate it? Well, we know that if we're looking at it, sometimes we're going to see the eyes. There'll be retinal blood in there because you're shaking the head and all the vessels, and it does. You'll see it in their eyes. Even petechiae, you'll see there. You might see bruising from holding the baby and shaking him, really hard. And then, of course, that vomiting, not eating, that lethargy, that irritability that happens. And then if they have seizures, it's all feeding into that probably shaken baby. So how are we going to take care of these children? Well, we really need to have alert, keen assessment skills. We need to do good neuro checks, looking at their pupils and looking at their movements and their arms and, checking that child for levels of consciousness. All of these things are really key. Nurses, sometimes it's all of a sudden, we see the level of consciousness. All of a sudden, this kid is not waking up like he should. That's showing you something. So very subtle. And again, it's us, the nurses, who see these changes happening. The physician is not there 24 hours a day like we are. So neurological monitoring in infants. Well, are they responding to pain? Older kids, you might see them do what we call take your fingers and rub the chest, on the sternum, a sternal rub. And that sometimes, that's showing you how lethargic they are. In infants, that fontanelle tells you everything. I mean, it tells you fluid overload, not enough fluid. It also tells you there's bleeding in the brain because now we have a bulging fontanelle. Posturing is a big thing. You know, they start arching their back and or these movements that just aren't normal. And then scalp veins right around the front of the ears are big veins in the infant's heads. And they start bulging because of the pressure coming from inside. And then that moral ortonic neck with withdrawal flexes, they draw in, they don't pull out. And that's a difference. Now, near drowning is all right, we have a hypoxic episode. Many children come into the ER, and I've seen it. We found him in the bottom of the pool. We got him up right away. We got him. He coughed out some water and he's running around the room. And the ambulance driver insisted he had to come to the ER. Well, it can be 24 to 72 hours later, these children go into acute respiratory distress. So just because they're up and running around doesn't mean that's the end of it, because it can be something that happens 1 to 3 days later. And we know we need to treat hypoxia. We need that kid needs high flow oxygen on. You know, the ambulance people need to put it on right away. And then if they're cold, we need to warm them up. Cold and hypoxia both need to be treated. So musculoskeletal, this is all about all of your things and broken bones, etc. And what do we do? Any questions so far? Okay, children, infants, when their bones are when they're born, their bones are softer. They're not completely ossified. That means they don't crack as easy. Okay, their epiphyses are present, which means there's spaces in places in the bone so that they can grow. Okay, and we know that these children, like for instance, an infant's born, we put them back to sleep for SIDS, right? That back of the head can get flat. And if we put them up on tummy time, we know it will round out. It's because those bones are still soft. So the musculoskeletal systems, they need each other. You need the muscles to pull the bones, to be able to walk, to be able to crawl, to do whatever they want to do, right? And we know that if we are looking at the musculoskeletal system, we want to see how are they walking. We want to see are the range of motion, are those arms and legs doing what they're supposed to do? Are they walking attempting steps by 1 year old? Or are they walking completely? It's they say 18 months. But you remember, if they're not walking by 18 months, we need to investigate. There are conditions with muscle weakness that we need to look for. Just because we don't see it earlier, sometimes it's when they're supposed to hit milestones that we find those sort of things. When you see a toddler, there's ways that they walk and they use their hands as they go. So toddlers begin to walk and their gait, they're like like a drunken sailor, right? They're side to side and they sway and they're so cute when they walk, but their arms aren't used. They just use their legs. Now, as they get older, by 4, now they're swinging their arms as they walk. These aren't normal things, that you would see. Now, if they're limping, they're favoring something, then we know something is going on there. So, problems with a bone, muscles, what are we going to do? Well, bone scans, CAT scans, MRIs, ultrasounds, all of those things. You want to see a picture of it. How does it look? Are the joints looking okay? Is there, what's the shape of those bones that we want to see? We do things like a CBC and a SED rate. Why do we do those things? Well, when you think of bones and you think of walking or movement, you have to remember there's joints in there, right? And sometimes there is something, like an arthritis. There's many sort of arthritises that could be. It could be rheumatologic, it could be a septic arthritis, something's going on. The CBC with rheumatoid or juvenile idiopathic arthritis is going to be the white count elevated. And the ESR is the SED rate. If there's inflammation because the body's attacking joints, that's going to be elevated too. And same thing with the human leukocyte antigen. So we see things going on. What are we going to do? Well, you see a lot with children with hips, knees, shoulders, elbows. They're not moving right.
Clean up.
Hello? You okay?
Oh, I'm sorry. I was talking to my kids. I'm sorry.
All right. Just making sure nobody needed anything. Remember treatment. Now, if it's a joint thing going on, you've heard of a knee arthroscopy. They go in, they look at the tendons, they look at the muscles, making sure it's okay. If we're seeing anything like an irregularity or outpatching, like a tumor looking on a bone, we're going to take a biopsy. And there is, osteosarcomas, tumors on the bone. We can put on traction. We're going to go into some of what that is. Of course, casting, broken bones, and splints. We use those a lot for like sprains. Now, one of the things that we need to teach, especially if you're going to be a school nurse, which is a great profession to do, is you have an injury. What is that treatment? They fall down, they twisted their ankle, and it hurts. Well, number one, they need to rest. They need to stop. They need to elevate that ankle, and they need to put ice on it, and then compression. If you've ever seen a swollen ankle due to a sprain, it gets quite large. So that elevating the ice, it causes vasoconstriction, keeps it from swelling. That compression keeps it. And of course, elevation keeps fluid from pooling there. Now, there's other types of things. They can have contusions, sprains, strains. I'm telling you, it doesn't matter if it's bruising, whether it's sprains, strains. Again, all of these things do work. I actually think I'd rather have a broken bone than have a sprain because they hurt longer, and that swelling, I think, is even more. But the treatment today is they are starting to cast and splint these ankles where they years ago only put ace bandages on these children, but they're realizing that they need to, keep that motion limited so that they can make it heal. So how do we prevent a lot of things? Well, pedestrian safety, these kids, out where they shouldn't be around cars. Car seats can help, with getting some injuries. Any safety equipment for anything, whether it's sports, whether it's you have a pool, keeping those windows locked, bars or locks, whatever you need, and then keeping things that safety, locking the cabinets of and keeping stuff that they can get into behind locks. So traumatic fractures. This is when a child, it could be, it's some sort of accident. They fall down, they're in sports, they slid into home base and you heard a crack. Or they slid, they're running and got into a hole in the grass and it twisted their ankle. And what do you see? Well, instantly there's pain and that tenderness movement. And then, as I said, it's going to swell. And because you've twisted it, whether it's broken or not, you've broken some vessels. So you're going to see some bleeding that goes on in there. And then with the bleeding, it includes your nerves, and that can cause numbness and paresthesia. Remember, whenever you have an injury, you need to be checking neurovascular signs. Now, what's neat about children, they have a fracture, it heals really quick. The younger children, in 4 weeks, we could take casts off of fractures and they're healed. Me and you, it could be 3, 4 months. Same thing, but because they heal quicker. Because it's stronger, it's thicker, and it has, what it needs to do it. Now, if you have a fracture, like a fractured femur, what pain medicine would you use? Would this be the acetaminophen? No, this is the one that you would give an opioid. You would give morphine to this child. Fractures hurt, and they need more of, moderate to severe treatment. And moderate to severe would be your opioids. And today we use morphine, and we use it very safely. All sorts of fractures. These are pictures of them. But here, let's discuss them. It's also in my review. Green stick is one side of the bone is broken and the other is bent. So it's not a complete breakthrough. Compound is the bone has come through the skin and now you're worried about infection. Anything bone comes in the skin out into the air, it's infected now. So they need antibiotics. And they'll usually put these children in the hospital and start IV antibiotics, depending on how severe that break is and where did they break it, what sort of materials got in there, and they had to flush it, clean it. Sometimes they go to the OR to flush it, clean it, depending, because they have to do some deep, cleaning. Simple fracture is the one that you fall down, and children love to put their hands out just like we do when we fall, and you see fractured wrists. One or two, whether it's one bone or two bones bilaterally. But all we do is that one is we put it in correct position and put a cast on it. Oblique is a fracture to the angle. The spiral fracture is the one you should be concerned about. I mean, the one thing you've heard me talk about is we need to protect our children. They're in our care. And we wouldn't do anything to hurt our own children, but there are people who do abuse children. So you see a spiral fracture. The only way you get that is abuse, which means you pull that kid and ripped it. Usually it's the arm, they pull it and twist it. And you'll see that bone twisted in it. And that really needs to be investigated. That is considered abuse. Now, I said we were going to do a little bit about traction. Now, why would we use traction? Well, Bryant's traction is usually for fractured femurs in young kids that are less than 2 and then lighter than 10, 20 to 30 pounds, okay? Because the feet go up in the air and it goes with a pulley system and then it pulls with a weight, okay? And what it does is a femur, when it's broke, the edges are sharp and it goes into the muscles, the thigh muscle, and it hurts. So we take the traction and we approximate the edges. So now you have it straight and you don't have all of that, those pain because of the edges of the broken bone there. Works well. Another thing we can do, and usually we do it older children, of course, that weigh more than the 20 to 30 pounds, and also fractured femurs. And usually we do it because they need to pull those bones out for, that pain, that discomfort, or because they go to surgery today. Years ago we didn't do that, but today we put rods in the femur so that it will hold it. But sometimes on the weekend, it's not done, right? Or maybe the schedule is full, or maybe that child just had a full meal. We can't do it right away. We'll put them in Buck's traction. And it literally, you take the foot and like a little shoe, and you put ace bandage around it, and it pulls it, and it pulls that bones out so they're straightened up and stops the pain. And again, it's a pulley to a weight, and it just holds it there. Now, Russell's traction is just like Buck's, but they put an extra piece that holds the thigh together. When do they use one or the other? It's a physician decision, but it pulls all of these things, approximate the edges so you decrease pain, and then it aids in healing. Now, cast and splints, there's all different things, right? So it could be made with fiberglass. It could be plaster. Some of the splints are almost plastic looking that we just blow them up and the air holds those ankles or whatever together. One of the things with these casts and splints, especially casts, children love to take things and put them down a hanger, and they like to scratch their leg because it, itches, right? We should totally discourage that. They say take a blow dryer on cool air and blow it in there, and that actually helps. And the one thing as nurses, again, any broken bone, any big ecchymotic crush injury, or even just a big ecchymotic area, check the neurovascular signs. It is swelling. It's maybe can occlude blood flow going to the leg or to the arm. So when you get a cast, if you work with a pediatric hospital, they got pretty colored casts. You go to an adult hospital, all they have is white casts. So I always say, if you want a pretty cast, go to the pediatric hospital. They have these pediatric orthopedic techs that put the cast on, that all they do is casting on children, and they really are amazing in what they do. Now, when they put them on, this foot should be left elevated to decrease swelling, and they say up to 72 hours because swelling can occur up to then. And on a nice soft pillow up, okay? And if they're in a hospital, you're going to be there checking their toes. If you can feel the dorsalis pedis on a ankle, you try to do that. Or if it's on an arm, the radial artery, we're going to check that, and checking the fingers, and if they're moving, and if you have all of those things, right? And then one of the things that I've seen, I can't even tell you how many times, telling these children to keep their cast dry. We do hand them out sort of bags that we put over the arm, the leg, the long cast, the short cast. Tell them if they shower, they need to do it. I can't tell you how many children went home, and I remember I live in Miami, and many of these injuries are right when school lets out, and they put on their bathing suits and go and jump in the pool. A wet cast must be changed as soon as possible because mold and whatnot can form in there and then create more problems. So I saw one kid do it twice, and he did it the same way. Went home, put a bathing suit on, and jumped in again. So we had to really remind him, please, because you always have to go back to the ER, get checked in. You got to wait. You got to get the old cast off, got to get the new cast on. Poor mommy, right? So what do we check for? And it's the 5 Ps. And these are Ps that you need to know what they are. Because when you see these things, it's telling you that there's some sort of occlusion in the blood flow somehow. So pain, pulse, pallor, paresthesia, paralysis. The pain's getting worse. You can't see a pulse. If you're seeing that the skin of the toes or fingers is getting white, it's not pink anymore. It's getting numb. They can't move it. They need to get in. It could be compartmental syndrome. An infection in the bone is called osteomyelitis. I've seen them just get a little nick on a big toe, walking around barefoot, and this is a dangerous thing when it hits the bone. Usually these children are those children ages 5 to 14 because they're up and moving around. And it is a bacteria, usually staph. And these children will need to be on a prolonged course of IV antibiotics, and then it gets switched to oral ones. Now, sometimes it's difficult to figure out because there's not a huge puncture mark. But you're seeing this stuff that looks like osteomyelitis. So, how do you find an infection in the body? Well, you couldn't do the assessment. Is it red, swollen, painful? All right, that's there. Well, do a CBC. And the CBC is going to show an elevated white count, show an infection. Same thing with sed rates, showing there's inflammation there some way. And then an X-ray may or may not show it. It's the blood work and physical exam. And then they might do a bone scan just to be sure. And as I said, long-term antibiotics. Usually these children get in that PICC line, the peripherally inserted central catheter, and they're sent home and they get IV antibiotics at home. So a nurse is jogging on a trail. Suddenly, a 10-year-old boy swerves his bicycle around her, loses control, and falls 8 feet in front of her. Initially, he denies sustaining any injury, but the nurse noticed he limps slightly when he goes to retrieve his bicycle. How should she handle this situation? What would you say?
Might want to get that looked at.
Yes, or maybe, I see you limping. Do you always limp? Remember, you have children that could, maybe minor cerebral palsy, right? Or an old injury or something. Check that. And then, of course, a medical history, are they allergic to anything? And if it's something like a sprain, elevate it, protect it. Do just that emergency treatment. When I was in nursing school, and I went to nursing school very, very young. I was 19 and I was very naive. And I was very involved in a volunteer fire department, believe it or not, back then. And I went and took a first aid course because they kept asking me how to do things, how to check things, how to look at stuff. I was in nursing school. You don't learn those things. But what I've learned with these type of situations, have them sit, have them relax. Let me go get your mommy for you to take care of you, right? Let's elevate it for what we can do right now. Check pulses, making sure that we have it there. All of those things would be a good choice. The kid is, probably embarrassed that he fell. That's nothing. Well, it could be. So I mentioned something before about something could be muscle weakness, right? This is a condition that is progressive muscle weakness. It's called Duchenne's or Becker muscular dystrophy. And the child usually is up walking, and then about 2, they start to get clumsy, waddling gait, and falling a lot. There might be some cognitive delays on these children because that's part of it. So they're like, okay, it's fine, but they continue to fall. You will see in these children big calf muscles, hypertrophic calf muscles. And you're going to see these kids progressively get worse. Now, we're going to figure out what we need to do. Now, we do something called an EMG. It's an electromyography. And what it does, it puts little electrical pulses into the muscle. And this little machine, and it's like little stickers mostly. They don't use needles a lot with kids. It's usually little stickers like you would EKG pads. And you give that little jolt of electricity, and they'll see how quickly the muscle responds to it. These children, they'll do that muscle biopsy. They'll be looking at some lab works on them, but this child is going to need therapy for life. Now, it's progressive muscle weakness. It is usually boys ages 2 to 7 where it starts to get to be really prominent, and you can really see it. These children will be on occupational, physical, speech therapy. And because it's muscle degeneration, eventually, and usually teenagers, their heart and their diaphragm stops working and they do die. So this is the outcome, it's not a long life, and it's going to be a lot of therapy with it. Now, a slipped capital femoral epiphysis. This is something where the hip and the femur and the bone socket don't sit there right. And usually happens when we go through that really big growth spurt, that pre-adolescent where they grow 20 to 25% of their height, and it slips. And this kid starts limping and starts to be in pain. And what they do is they put them on bed rest. And this one is going to get Buck's traction to pull it, to relax it, to relax the muscle so that it can come back in. It usually goes back in, and sometimes they'll need to do surgery on them, sometimes not. So we also call it coxavera, okay? And as I said, it's a limp, it's pain, and they're going to put bucks on these children. Late calf purse disease. This is coxaplana. And this is an aseptic avascular necrosis of the hip joint. And again, same sort of symptoms in it. And it's not an infection, so you don't give them anything. And what we need to do here again is treat them with NSAIDs for pain, bed rest, and then some of these end up later in life with hip replacements because it stops the blood flow from the head of the femur, that ball there. And again, shows limping. I mentioned osteosarcoma. This is usually on these children, it's a femoral bone cancer. And again, progressive limping, pain in the leg. And they say children with a retinoblastoma have a higher incidence of it. And what we do for it is we take the femur bone out, the whole thing. You can't leave it in there. But what they do is they take the lower leg, your calf, pick it up, turn it around, and reattach it to the hip. And why do they do that? Well, they need somewhere to put a prosthesis. These kids are normal in every way, but they had a cancer in that bone. Also, catching it early enough so it has not metastasized is the big thing. And this is going to be just like any amputation. They're going to have that phantom pain that you do see because literally it is an amputation, but it's the whole leg. And usually they salvage the limb, it's what it's called. Healing sarcoma again is big bones again. And you'll see it in jaws, you'll see it in arms, legs. And again, this is what they do is radiation therapy, and they do chemo on these, and that usually will get rid of it. I've mentioned JIA. It's also called juvenile rheumatoid arthritis. And this is an autoimmune condition where the body doesn't like its joints and it attacks it. And they get swollen and it's painful. I can tell you because I have rheumatoid arthritis. extremely painful. Now, the hard thing with this condition is very, very hard to diagnose. Very hard. So it takes a while to get that diagnosis. Once they have it, they can start the medications on that. And remember, with this, there are different sort of juvenile idiopathic arthritis. We can have one that's just a systemic one, that you have this rash, abdominal pain, but anything in the body that has an inflammatory factor, sed rate, C-reactive protein, white blood cells, we'll be looking at that for all of them to be elevated. And that's usually what you see. You have polyarticular, which is 5 or more joints. That's me. I have it all over the place. And then you have some that is limited to 4 or fewer, which is parsa-auricular. So in JIA, there's different things, and we do treat them with biologic medicines. I take an infusion once a month. Torticollis is a stiff neck. The neck is just stiff to the right, stiff to the left. Sometimes they're born with it, and it will need some physical therapy in order to, get that neck muscle to relax and to straighten up. And usually they're fine with it, and it does hurt. Older kids get it, it hurts. I mean, have you ever had a stiff neck? It's very uncomfortable, it's bothersome, and it's a muscle spasm. The sternocleidomastoid, it's really tight and it causes pain. Scoliosis is the S-shaped curvature of a spine. And this again is that pre-adolescent growth spurt where they grow at that 12-ish to 14 age, where they get taller quicker. And you will see these children where that arm and that shoulder's good. One's higher, one's lower. One arm, when they bend over, is longer than the other. And if you look at their spines, it's an S-shaped. Now, you can have up to a 40% curve, because if you look at that curve, it sort of goes into the lung area. So lung expansion is going to be decreased on some of them. So you want to get it back up as far as you can. If it's 40 or more, they're going to do a surgery, usually a spinal fusion. And it tries to straighten it up. But less than 40%, they are going to put these children with physical therapy. And they're going to be wearing this brace with something underneath 23 hours a day, which means they'll just take it off to take their bath every day. So a mother gets a call from a 12-year-old daughter's school nurse. The nurse informs her that her daughter has scoliosis, which was detected during a routine school testing. The mother's never heard of it and is concerned that her daughter will be crippled for life. What are you going to tell her? Anybody have scoliosis here? Know somebody? My daughter's best friend had scoliosis, and you could see her get more crooked right at that 12 to 14 age. And then she went through therapy, and she's, still a little crooked, but a lot better than what she was. So it is not crippled for life. It is really not painful. It just requires prudent exercising, and keeping those muscles, loose and working the way that they should. Sports injuries, the biggest thing is to wear proper equipment. Kids are competitive. They're going to be, running, jumping, all of these things, because Maslow is esteem, right? Maslow's level of hierarchy. You play sports, those who do it well, because it makes you feel good about yourself. There's concussions, there's stingers, injured knees, ankles, muscle cramps are huge, and those shin splints, because, you're working and doing things repetitively. I mean, there's all sorts of sports. Family violence, all families, all cultural, social classes all can be affected by some sort of abuse, neglect, or maltreatment. It doesn't mean one class is more than the other. They're all the same. And again, as a nurse, your job is to protect children. You know, I can tell you off the top of my head, I can remember 4 that came in that, you know, I was very involved with. And it hurts to be involved with them, but you're there for the child. So we know that abuse is could be poverty, you know, family, poverty, unemployment, or the family just doesn't get along. Lots of yelling and screaming, mom and dad, or maybe it's a multi-family unit, you know, and they're all, you know, arguing with each other. It could be that you have a child who's disabled or needs extra help, a hyperactive child, one that doesn't slow down and it was wearing on, you know, a parent or whoever, and they ended up, you know, abusing them because they just wouldn't stop. It could be a foster or stepchild. And it could be substance abuse in the family. A lot of times it is the financial that, you know, parents, you know, money is always a problem. It's always an issue, but it's how you work with it. Now, parents are more apt to be in this child abuse if they were abused as a child, if they have low self-esteems, and if they're overworked, you know, and overwhelmed with their life. Of course, it is substance abuse, whatever the substance is, you know, all of those things can cause abuse in children. And there's different types of abuse. Emotional abuse, which, you know, you're telling them you're stupid, you don't know what you're doing. Emotional abuse, where they do not show you love. They don't hug, they don't kiss, they don't express it. Sexual abuse is when they do sexual things that they shouldn't. Physical is when they don't have food, clothing, shelter, right? And then physical abuse is when they are inflicting pain on them. Now, there are bruises, and they can tell you how long they've been there. I had one 3-month-old baby, infant, came in, abused. And behind the ear was this swollen area, and it was greenish purplish when I saw it. And I picked that infant up to put it on the scale to weigh it in the triage area, and my finger smushed into this child's brain. And I was tender as tender because he was crying. And I went, okay, I know what's going on here. And you know how that makes you feel, just sick. So I did tell the charge nurse, I did tell the physician. I actually brought the child over to x-ray. We did what we call bodygram, x-ray from head to toe. And we found a fractured skull, fractured femur, fractured ribs, fractured humerus on one 3-month-old baby. To tell you, the perpetrator is in jail today. So that's the end of the story, but it does. I'll never forget that child. So reporting, you do have to report. You know, it's important. Remember, you're the eyes for these children, you know, to keep them safe. So they do, you know, DCF, police, all of those people were called in on that case. So intervention, you see a kid who is neglected, you know, you got to teach this kid how to deal with it. You know, they're going to need some psychological care, that anxiety reducing techniques, you know, how to cope, and how to manage how they feel. I mean, what if it's your father, your mother, your favorite uncle that are doing things to you? You really have to deal with it. And as nurses, remember, people who bring these kids in, yes, some are the abusers, but remember, parents are there with their kids to get care. Remember, they need support also, okay? In the cases that I saw, only one was the person who did it. Okay, so the mother who brought the 3-month in, needed, you know, to have somebody support her. Call the social worker, call the patient rep, call somebody to give her help. So cultural and medical issues, remember, you must think about the culture of the person and be very sensitive of it. It could be as in no male nurses for their daughter, or it could be diet, or it could be not uncovering them all at one time, only little pieces at a time as you're assessing. All of these things, we learn as we are nurses, and to make sure that we do, if we're sitting there and we're going and assessing these children, to be very sensitive with all these things, because these children are going to remember you. So long PowerPoint today, a lot of information. I think I covered it all. I will be sending you all the Kahoots for you to do. It's too long for me to do right now. So any questions? Remember, next week is going to be your exam. So come prepared. You've got a good review from me. Make sure that you look at it, listen to it. And there is another one on Sunday at 5 o'clock, right before Super Bowl.
Professor,
Yes.
so all of this will be for our next exam, right?